It is an election year, and for those of you who don't remember, President Trump is going up against Joe Biden. And I think they have their first debate tonight. Anyway, that being said, at Duke Spine Institute, located here near Orlando, Florida, we're performing spine surgery. And today we're going to be doing a Duke laser disc repair cervical on a patient who has 2 herniated discs in her neck. She has an MRI that shows herniations at C5-6, C6-7. So she had the opportunity to have a fusion done, an anterior cervical discectomy and fusion. She didn't want to do that. She wanted to try the laser surgery. The laser surgery we do is done without fusion. It's done anteriorly. And it's not just a discectomy, but it's an annular debridement. Shot. I need to see better, so you need to go maybe a little bit north. You need to hurry. I don't know how long my fingers can last like this. Shot. Is that it there? Yes, sir. Shot. All right. So 2, 3, 4, 5, 6, 7. So we can go a little bit north. Beautiful job on the neck. It's supple. We have Dr. Santiago here. We're very truly blessed. Come on, Jordan. I need you to get that better. Let's go. 2, 3, 4, 5, 6. Yeah, I still need a little better. Let's do a shot. I've got to be able to see the needle, Jordan. 2, 3, 4, 5, 6, 7. I cannot see. You got to get these wires out of here. What do you? Don't hit my hand. You got to not touch my head. Jordan, come on. We need this done. You need to go further south, Jordan. Come on. Shot. All right. Do we need Monica here? So, for those of you joining us for the first time, the way we do these surgeries on the spine and all spine surgery, you have to have a knowledge of exactly what disc you're operating on. You'd get that beforehand from the MRIs, X-rays, CAT scan, and then when you're in the operating room, you use an X-ray machine usually to find the correct levels of discs. So that's what we're trying to do right now, but our X-ray machine needs to be calibrated properly here and positioned properly, aligned properly, and the right amount of radiation, collimated in the right way so we can see the spine properly. All right, are we pulling on shoulders? So, I mean, we have a nice view. 2, 3, 4, 5, 6, 7. 2, 3, 4. Well, you had it nicely. I guess that's okay. You're still overexposed. Either you have too much penetration or you're under contrasted on the post-processing. I don't know which it is. I mean, even that's fine, but it's still overexposed. So either you're too much radiation or not enough contrast on post-processing. 2, 3, 4, 5, 6, 6, 7. All right, well, I'll try again. So we have the patient's head and we have the front of her neck right here. And I'm going to go back and palpate the front of her spine. This is the hardest part of the surgery. Shot. So 2, 3, 4, 5, 6, 7. Once again, shot. Give me an AP. Just a quick AP right now. No, don't line everything up. Just give me a quick AP. Come on, man. That's good. Lateral. Quickly. It's not time to be slow. So my fingers are actually being used under a lot of pressure to get down to the spine. So if I don't get relief soon. So 2, 3, 4, 5, 6, 7. Everybody agrees? Shot for the side. That's good. All right. I got to release my fingers, which are killing me, but that's the hard part about the surgery physically for the surgeon is holding down on the neck properly so you can get the needle in position. All right, so that's our lateral there. Wait, stay there. 2, 3, 4, 5, 6, 7. Yeah, go ahead and do a quick AP. So the nice thing is she has a perfect neck for the surgery. On a scale of 1 to 10, she's a 10. All right, that's perfect. Just stay there. I'm going to go ahead and do my discogram. I'll need the coker back. Just wait, guys, wait. So we're going to inject a little bit of dye so we can outline the herniation. Shot. There it is. You can see the dye going off to the patient's left, going around the nerve root. It's actually on both sides. There's tears, but the big one is on the patient's left. That's where the big herniation is. Lateral view. Y'all see that on the AP? So the dye we're using, shot. Get a better picture than that, please. Let me know when you guys are ready. All right. 2, 3, 4, 5, 6, 7. Everybody in agreement? I need a better view of 6, 7. Who's not pulling the shoulders? Are we pulling? All right. Shot. That looks pretty good right there. Just stay there for another second. No, I'm not ready for that yet. Shot. Good. Almost done. So we're getting the guide wire in there, taking the needle out, and let's just make sure we haven't moved. Shot. Perfect. You can relax. Everybody relax a little bit. We're going to numb up the skin. We're getting ready to make our incision. There's epi in there. I'd say 1 mil injected. The rest of it came out. So our incision is 1 millimeter, sorry. I'm sorry, it's 4 millimeters. The incision in the skin is 4 millimeters. It's very small. So it heals very quickly. I may have to make it a little bigger. It's kind of hard to tell exactly if it's large enough. Shot. Want to make sure that we don't advance the guide wire down. What's that? Oh, you just pulled their arms. Not too hard. Shot. That's pretty good right there. So I'm advancing the dilator through the tissues, and we're making our way. You can relax a little bit, just a little bit. Do a half pull. So to take the herniations and repair them, shot, we're going to go through the front of the spine. There's 2 ways to get to the cervical spine areas that have herniations. One is through the back, the other is through the front. The front is much better than the back because the herniations are always in the front. Shot. So the best approach is just as we're doing through the front, called anterior. Now, most surgeons do a much bigger incision. Shot. All right, I need to see the guide wire. So pull harder and let's get a shot. Aha. So it has come back a little bit. Shot. Yeah, right there is good. Shot. So you got to be mindful of the guide wire and make sure it doesn't migrate or move while you're doing the surgery. Shot. All right, so at this point I'm ready for an AP view, Coker. So the best way to get to a herniated disc in the neck is through the front, not the back. And There's different surgeries that can be done through the front. The most common is an anterior cervical discectomy infusion. That looks perfect. So you can see the tip of the dilator is right in the midline. So I'm right between the two longus coli muscles in the front of the spine, right on the anterior longitudinal ligament. You see the guide wire goes past the front of the disc towards the left side, which is where herniation is, more to the left side. So at this point, I'm going to advance the dilator into the disc. So I still need another lateral shot. Yeah, that's perfect. So I'm going to use my fingers to just feel as I go through the anterior. There it is, right through the anterior longitudinal ligament shot. Perfect. I'm in the disc so I can take the guide wire out. And I'm going to advance the tip of the dilator to the back of the disc. Shot. Right where the herniation is. Shot. Perfect. So I'll only need an x-ray for another minute here while I bring the actual tubular retractor down. So the sequence that I'm doing of steps is the same for every patient. It's needle, guide wire, dilator, and then tubular retractor. The whole surgery will be done through this tube. It's called the tubular retractor. And the way we do this is with the endoscope. We do endoscopic surgery. So for those of you who have never seen this before, this is the endoscope, the camera, the laser fiber, irrigation, light source. And we're going to place the endoscope right down the tubular retractor and out the bottom. Okay, and right at the bottom is where the herniation will be. Take that. All right, so the next step for me is I've got to bring this tube all the way down to the herniation. So the tip of the tube is where the herniation is. Now the tube's diameter is 4 millimeters. That's why the incision has to be 4 millimeters. But can you imagine what an incredible small incision that is? The recovery from this surgery is virtually an hour. And then by the next day, people are back to normal activities, except they can't lift anything heavy and they can't play contact sports yet. So heavy lifting and contact sports should be avoided until the spine is completely healed. So everybody gets a 25-pound lifting restriction. Now you can see right there in the x-ray about halfway down is the front of the tube. So I was saying that the cervical spine herniations can be approached through the front or the back. The best way is through the front, always. Going through the back is not good because you have the spinal cord blocking you from getting the entire herniation out. The best you could do is a foraminotomy, or you could do a laminectomy, but that's a major surgery for such a simple thing to fix through the front. The surgery you're watching is called the Duke Laser Disc Repair. It was created here at Duke Spine Institute. It's done nowhere else in the world, and it is anterior cervical endoscopic surgery. The first people to do anterior cervical endoscopic surgery were the South Koreans, and that's who I learned the basic technique from. But the specifics of this surgery I developed myself here at Duke Spine Institute over the last 15 years. All right, so we're going to advance the tubular retractor down into the disc space. Right now the tube is at the front of the disc, and I'm going to bring it down. Shot. While I'm doing that, I want to make sure the dilator doesn't pull back or go forward. Right now it pulled back a little bit. Shot. So I need to advance it again. Shot. And the goal here is to get the tube right at the base of the herniation, right at the beginning of the herniation. And then I'm going to use the laser and endoscope to take the herniation out. All right. That's pretty darn close. Let's see if I can get a little bit closer. Shot. Shot. That's about as good as I'm going to be able to get it right now without removing some of the herniation. So we're going to take the dilator out, and what we're left with is the actual tube. So we're in good position. We're at 2, 3, 4, 5, 6, 7. C6-7, we're going to do this disc, and then we're going to go to the one above. I want you to notice the curvature of her cervical spine is perfect. She has a lordotic curve. We like it. And the disc spaces are big. So she doesn't need any implants put in there. She doesn't need a fusion done. She doesn't need artificial discs. She just needs the herniation taken out. And what we're able to do here at Duke Spine that nobody else in the world can do is we can take the herniation out without taking the whole disc out. Because of that, we don't have to do a fusion. We don't have to put anything metal or unnatural in her spine. All right. Let's get started. Keep that scope sterile. Move it back, please. Get your Raytech ready. I'm going to reach down and see if I can grab a piece of herniation. There's one right there. You all see that? So that's a piece of the herniation right there. Sean?
We can see it.
It's small, but these herniations are small fragments of disc material, nucleus that's in just the wrong place, basically, to cause pinched nerves. All right, at this point, we're going to go in and bring our scope in. Move this way. So we're going to head down this tube, turn on our irrigation. You can see little fragments of blue, which is the nucleus pulposus, the herniation itself stained blue. And I'm going to bring the laser fiber forward so we can see it. There it is. And that laser fiber is going to deliver laser energy right to the herniation. And as it does that, it's going to break up the herniation into little pieces, and they're going to come out through the tube. Now, I've done in my career, in the last 15 years that I've done this surgery, I've done over 1,000 of these surgeries. Most of them are on people's backs for herniated discs in the lower back, for back pain, leg pain. But I've done a large number of cervical disc laser surgeries as well, endoscopic surgery. My total numbers are around 1,200 to date. And we just started this year in 2020. It's been a horrible year for everything else because we had COVID-19. We've had economic fallout in the United States and travel restrictions and everything. A lot of bad things have happened to people this year, but the one good thing is Duke Spine Institute started doing thoracic herniations. And we tried it on a few patients that had no other choice, really, and it worked. It worked well. So now we've done 6 thoracic herniations to date. That's a piece of herniation, by the way, in case you're wondering. We've done 6 thoracic herniations to date, and all the patients have had 100% relief of their pain, 100%. So where they had severe pain in the thoracic region, it's gone. And we've had 0 complications. So the reason I hadn't done thoracic is, number one, it's the most risky, in my opinion, of all the types of endoscopic spine surgery. And number two, it's never been done in the world. Endoscopic transforaminal thoracic surgery, disc surgery. There's only one other surgeon I know that does endoscopic, and he goes through the chest, through the thoracic cavity. It's very risky and has to be done in the hospital, and you have to drop the lung and the heart has to move over, and it's extremely dangerous surgery, and it's done by a pioneer out in Phoenix. But it's major, major risk, blood loss, and complex. So we did a transforaminal thoracic here at Duke Spine. We're the first in the world to do it. And that's where we went in and took the thoracic herniation out through a posterior approach, where I went in paramedian off the midline, and I went through the foramen, the thoracic foramen, and I was able to get the herniation out through the thoracic foramen. These are all fragments of disc. Remember, this is C6-7. So this is the bottom disc that we're fixing. Look at, there's a big herniation right there. You see that? Right there. Let's try to grab it out. So when we talk about a disc herniation, it's never, we always talk about it as a disc herniation in the singular, but the herniation is really made up of, you know, multiple fragments of disc herniation. Just on the MRI, it looks like one, but it's really 10, 15, 20 pieces. Rarely do you get one giant piece. Rarely, like probably 1 in 50, maybe 2 in 100 will you get one giant piece. But mostly it's little chunks like this guy right here. And you just got to patiently remove all the little chunks. So I float them up. It's called floating out technique. I developed a technique here. It's a new technique. And I just float them out using irrigation. We call them floaters. Maybe you've heard that before, but not in the medical term or medical sense. So I have a Dr. Santiago is here with us today. He saved the day. You did? You know. The anesthesiologist that we normally work with, apparently he tested positive for COVID. So we had to cancel him. And this patient, our patient here traveled all the way from Kansas, which we're located here in Florida. We get a lot of patients traveling from around the world and the United States. So this patient showed up ready to have surgery, and we had done the Skype with her, and I'd looked at her MRI and done an MRI review over the internet, and I knew that we could fix her problem without fusion, and that made her very happy. So she came here for her surgery, and then the day that she showed up, the anesthesiologist told us, I've got coronavirus, positive test, I can't come. So we did, of course, we would never want to expose our patients to anyone who has active coronavirus. So we canceled the anesthesiologist, and we contacted Dr. Santiago, and Dr. Santiago agreed to come and help us, and it was huge. It's a long drive for him and time away from his family and practice. So he saved the day. He's the hero of the day. Yes, for sure. Otherwise, I'm sure the patient would be angry with me. Okay, careful, don't let those cables go down to the side. Yeah, that's the non-sterile area. Oh, that's a big herniation right there. Look at that. Floating out. So, to me, this herniation doesn't look that old. I don't know when her injury was, but this looks like a more recent herniation. It's not as scarred in. There's another piece. See, normally, for those of you that watch this, you see these chunks are scarred down really good. And I got to work on them for a long time with the laser to get them released. But her fragments are coming out nicely. Oh, look at that. Beautiful. There's another piece. By the way, just so you understand, on the left is the end plate, and on the right is the end plate. So I'm working right between the two end plates. The end plates are the bones, the vertebral bones, the vertebral body bones. I'm working right between them. Like I said, this herniation, I'm actually able to go side to side. There's a big chunk right there. See that? I'm going to try to grab that out. So my voice may have changed for some of you who watch me all the time, and the reason is I had sinus surgery on Friday. I broke my septum about 35 years ago playing basketball, and I didn't know it was broken. And I lived with it all these years, and I had more and more difficulty breathing. Of course, my voice was very nasally, still is today, but I saw an ENT doctor, and he said we can do endoscopic surgery and fix it. I said, okay, how long am I going to be out of work? And he said, you can go back to work. We do it on a Friday, you go back to work Monday. I thought that was pretty good. So of course I got it done, and he did a great job. Like everyone else, I'm scared of having surgery on myself, right? You never know what the result will be. You always worry. I worry about complications. Maybe other people don't worry as much as they should about complications, but I worry about complications. I know what complications are. I know how bad they can be. And that's one of the nice things about the surgery you're watching right now is we've never had a complication. In 15 years of doing this surgery, over 1,200, never a single complication. And the blood loss is minimal to none. So I had my surgery done on Friday, and I was supposed to be back on Monday, but they put some stuff in my nose, these plastic dividers, and they were making me crazy. They were irritating my sinus so bad, my nasal cavity so bad, I had to get them out yesterday. Couldn't even make it to work. But here I am today, and we're doing this surgery, and I'm feeling pretty good. Still need a few more weeks to fully recover, but I'm able to work. He released me to go back to work. But the whole experience got me thinking about what my patients experience with their endoscopic surgery. And I gotta say how fortunate my patients are to have a type of surgery on their neck where there has never been a complication. And it's so safe and effective, getting rid of 95% of the pain on average. And the recovery is just an hour. It's amazing. I thought my endoscopic sinus surgery recovery would be quick, but it's taken me days to recover, not hours. So it's amazing that we can do spine surgery, fix herniated discs with 1 hour recovery, when even sinus surgery done endoscopically takes days. I was reflecting on that. You have a question for me?
I do not have any right now.
No questions? Audience knows everything? All right, there's a herniation. Let's go get that guy. Monica, how are you today? Look at that piece right there. That's big. Of course, it's like 4 millimeters, but it's big. So, how good was it?
It was beautiful.
All right, beautiful. All right. So what does that all mean? Like, I need the laser on?
This machine is a low dose.
Uh-huh.
Lower dose, even with the normal, kind of runs off a high basal mass.
Yeah.
The dose is basal. It's a 40 kilowatt output, so it's got more power than what our other one has.
Uh-huh.
The images are great.
All right, so what's the hardest image to get good?
For us,
Normally.
it's lumbar.
No, like is it the thigh, the hip? What's the hardest to get a good x-ray picture of? Just in general. That's always the hardest. And for all x-ray techs, if I asked them, they would all say the same thing, pretty much, lateral lumbar. No, but I'm talking anywhere. Like what is the hardest to do? What? Sacrum? So that's got a lot of meat. Do we do any of that?
We did not have a sacrum plastic, so we did do the lumbar and thoracic on a larger patient.
Uh-huh.
And the images are beautiful.
All right, so you're very happy.
Yes.
Okay, it's a new machine.
It's a quick demo. We kind of had it out for a couple of months.
Uh-huh.
Took time to work on
I mean, it's a 2020.
I might be a 19. I'll have to go back and look again. It's small.
Standby. Small. I mean, what matters to me is the quality of the pictures, the speed and efficiency of the machine. and the ability to import those images into our PAC system.
Ticks every box.
Huh?
It ticks
It's very efficient,
It is a
very
very
good quality pictures.
Yep.
If and and then you're saying it's also very safe.
Yes.
Does it have a what about taking post-op pictures for fusions?
It's perfect.
Okay. You can get cervical, lumbar.
The maneuver, the machine itself is smaller than what the one we had is.
Is it a digital plate?
It is wireless.
Wireless. All right. And we got to start talking about warranty and software upgrades. Like, what are they going to include? Maintenance. What are the maintenance costs? Like every year, what kind of maintenance it's going to need. But good. Sounds like we're off to a good start.
We are.
What other company are we looking at besides them?
That particular one was Samsung. There is another one that's a little bit older and a little bit less expensive. However, that one is not available for us to check it out. It's kind of it's a used one, so
Uh-huh.
we're not going to ship it here for us to try.
Is it a Samsung, the other one?
It is not a Samsung.
What is it?
GE,
GE?
if I remember correctly.
Yeah. All right, that's the foramen, by the way, and things are looking good. I've gotten all the herniation out. The nerve root's just up there. I don't see anything else. Hey, which is worse, 6-7 or 5-6 on that MRI? I can't remember. By the way, that's the posterior ligament there. I've gone across from one side to the other. All the herniation is out. I'm very happy. We actually found herniation on her right side, though her symptoms were really mostly on the left. We got the right herniation out as well. That'll help her. Huh? Good. I'm just making sure I've gotten everything I can. I'll be done at this level in just a minute, like one more minute left. That's the foramen right there, by the way. I think I told you that. Uncinate process. There's really nothing more in the foramen. It's completely devoid of herniation. Just some ligament. It's thickened. But all the herniation is gone. That's just posterior ligament right there. I don't see any more herniation. I think we're done here. That's the good news. So she had two herniations. The number 6-7 is the worst. We just finished that one. Next is 5-6. We're going to do the 5-6 next. So I got to take this dilator out. Take the tubular retractor out, leave the dilator, watch the laser, turn off the irrigation. All right. I'll put pressure for just a minute while we wait. Let's get the fluoro back in. You got to watch the tip of that. Release that, pull the laser back. You don't want to break the tip off. So we've taken the herniation out at C6-7. Next is going to be the 5-6 herniation. It's not as big. Here's some herniation, by the way, if you want to add it to your collection. Let's go. Wait, go back down again for just a second. I want to drain the bag. That should be good. Thank you. That's good. Let's get ready to pull on the shoulders. And whenever you're ready, get an x-ray shot. All right, beautiful. So move the fluoro a little bit north so I can see 2. And shot. That's perfect. So 2, 3, 4, 5, 6, 7. We did 6, 7. You agree? Next is 5, 6. Everyone agrees, the one above. So I'm going to head up there next. And this is another tricky part of the surgery. Shot. No, relax on the arms. Shot. We're out. Now I got to move north. Shot. I need an AP. So I'm off to one side or the other, and I got to figure out which side. Oh, right here. Hold on. And Coker. Shot. No, I need a better shot than that. Shot. Get that centered. You're rotated a bit. I know she's got that scoliosis, but let's try to compensate. Other way. That's better. Yeah, we're pretty good. All right, let's go back to a lateral. Shot. All right, so I need that back in a second. We don't need that yet. Don't even bring it to me. Shot. All right, now I need an AP. Oh, no, you hit something and it slipped. So let's give me a lateral. And don't hit the table, please. All right, back to an AP. You're not allowed to hit the table. That's clumsy. We don't do clumsy stuff here. All right, so we're off to the side. I need you to line that up in the middle better. Shot. That's better for both of us. It's a little slippery. Shot. Lateral. Get the mallet ready. I need a lateral. All right, it's a little lower than I want it to be. Shot. AP. The lateral looks good again. See the AP. You don't want to move this thing forward unless you're sure where you are. A little bit too much to my side. Shot. Shot. Lateral. That'll work. Shot. Let's get an AP. I just want to make sure hasn't moved.
A couple questions.
Sure.
One of our viewers is wondering, if this patient got whiplash,
Perfect.
would this disc
Lateral.
re-herniate?
So the question is, if this patient got a whiplash, would this disc re-herniate? The answer is no, it would not, as long as the disc was healed. How long does it take to heal? It takes really 6 months to a year to fully heal. I tell all the patients a year. Shot? Just because a year is the safe number. Shot? So if the whiplash happened a year after surgery, shot, I wouldn't expect any herniation. If it happened tomorrow, right after the surgery, they wouldn't herniate either because they're wearing a collar. All my patients wear a collar. Shot? All right, there's some dye. It's gone out the tear in the back. You see the tear? And it's outlining the herniation. Give me an AP, Coker. So we just did a discogram at C5-6. Shot. Perfect. You see tears on both sides. So she's got tears on both sides with dye going out both foramen, but she's only symptomatic on the left. Really, that's her primary symptomatology. Yeah. And now we're going to advance the dilator. Shot. All right, I just need to get it back in the disc. Shot. All right, let's get the tube over it. So you all saw me do this last time. We're going to do the same sequence now. Tubular dilator goes tubular retractor goes over the dilator. I advance it through the soft tissue. Remember, the advancement through the soft tissue is the same now as it was last disc because we haven't made a new hole, have we? Shot. We're using the same pathway, the same skin incision, the same path that we used for the first one. So there's less trauma. By the way, if you've ever heard of anybody having a neck fusion through the front, that all those people have trouble swallowing. And the reason they do is the surgeon has to move over the trachea, the esophagus, all the soft tissues they have. We have to cut not through them, but around them. And what that does is it causes inflammation in those tissues. And those tissues then, because of the inflammation and trauma from the surgery, they have a sore throat. They have patient has trouble swallowing. They have a sore throat. Sometimes they have hoarseness that goes on. So by doing the laser surgery, endoscopic, we don't have any of those problems. This patient won't have a sore throat. They won't have hoarseness. They won't have trouble swallowing because the surgery was done endoscopically. Fluoro out. Again, if you want this surgery done, your surgeon by your house won't be able to do it. It's only done at Duke Spine Institute. All the other surgeons in the world are doing fusions and artificial discs, which are much more invasive and much more destructive. You don't want that surgery done. This is the most advanced surgery in the world for a herniated disc. All right, what other question do you have there, Sean?
We have another question. One of our viewers is wondering, what was this patient's symptoms that warranted surgery?
This patient had neck pain. They had pain down their left arm. They had, I believe, weakness in the left arm, some numbness in their hand. So every patient's going to be a little bit different, but the symptoms are that of radiculopathy, cervical radiculopathy, which is either an irritated nerve or a pinched nerve in the neck. And they had two herniations, one at C5-6, one at C6-7. And the bigger one was at C6-7. We've already fixed that one. The smaller one is at 5-6. And they wanted both herniations fixed at the same time. They didn't want to have two surgeries. So we're doing them both. And the herniations were irritating the nerves going down the left side. So neck pain, arm pain, and a little bit of numbness. I don't know if she had weakness. I can't remember. You guys know? And she had some headaches too, kind of at the base of her neck going up towards the back of her head. Those are all very common symptoms from a herniated disc. Neck pain, arm pain, headaches, and numbness in her hand. All right. Go ahead, Sean.
We have a follow-up to that question. The same viewer asked, can vertigo be a symptom of a herniated disc in this area?
So can vertigo, which is the room spinning around you, can vertigo be a symptom of a herniated disc in the neck? The answer is no. I've never seen vertigo from a herniated disc in the neck. I would be looking for other causes, not a herniated disc. I do get patients from time to time. They tell me that they have vertigo. They wonder if it's going to get better with surgery. I tell them no. Don't expect it to get better with surgery. Now, that said, some people get panic, kind of like anxiety from a herniated disc when it starts hurting. And they can get lightheaded, anxious, and obviously once you fix the pain from the herniated disc, those symptoms can get better and go away. But true vertigo, which is the room spinning, it usually comes from a problem with the labyrinth. I would not expect that to get better with this surgery or any surgery on a disc. We got about 5 more minutes. Maybe 6, 7 max. Yeah, but you know how my 5 minutes can be. These are all pieces of the herniation. Great questions from our audience. So this patient is going to go home right after the surgery. She's going to go back to her hotel and then come in tomorrow, see me for a checkup, and then be back on the plane tomorrow to go home to Kansas. The surgery here at Duke Spine can be done with 3-day turnaround. In one day, surgery the next day, home the next day. And if you really, really want it to be quick, we could do the whole thing in one day, as long as we do some planning ahead of time. This surgery is not available anywhere else in the world but here in Florida. Yes, Sean.
We have a viewer wondering, I have bone spurs at C5-6 pinching my nerves. Can DLDR treat this?
Yes. Yes, your bone spurs can be treated with this surgery. This laser can go through steel. It cuts through steel. So bone spurs are easier to take out than pieces of steel. Now, if all you have is giant bone spurs and no herniation at all, then that's going to be difficult to do the surgery for. So the real answer is I need to see your MRI, but the truth is the laser is able to treat bone spurs, no problem. We do it all the time. As a matter of fact, that right there is a bone spur. See that? I'm blasting right now. It's not a big bone spur, it's a small one. I'll bet you would be able to get this surgery done. I just need to see your MRI to confirm that. I'll show you some more bone spurs in a minute. These are all little pieces of herniation. Remember, I told you they don't come out as one piece, unfortunately. That's bone spur right there. The golden color stuff that I'm working on. The blue stuff is herniation. This is out the foramen. This is the left side at 5-6, C5, C6. This is herniation here. Trying to clean it up. Bone spur right here. Got rid of it. You see that right there, the golden stuff? That's all bone spur. Easy to get rid of with a laser. Almost done. So this is endoscopic spine surgery. You're seeing back of a disc herniation in the cervical spine. And we're at C5-6, and right there is the dura. You see the white stuff just below where my laser is? That's the last fibers of the posterior ligament. This is the neuroforamen I'm in right now. It's a little bit of scarred in herniation right there. I'm zapping away. That's a bone spur right there. This thing right here is a bone spur, but it's not on the nerve. It's close to the nerve. And I'm not going to get crazy with it. I got rid of most of it. I'm not going to get rid of all of it. And guess what? The patient's not going to have any symptoms from it. So the goal isn't to get rid of all your bone spurs. The goal is to get rid of all your symptoms. And the problem is you get surgeons who don't understand that. And they try to gild the lily, and they end up causing complications unnecessarily. Any other questions?
None so far.
All right, just about done. So we're going to be done here in about 2 minutes, and I'm going to head over to the conference room, and I'll answer any questions you might have.
We have another question.
Uh-huh.
So one of our viewers asks, if you did a spinal decompression laminectomy and it was successful at curing your nerve symptoms, is the herniated area still there and will problems come back in the future and need surgery again?
So if I do a spinal decompression where the herniation is, stand by, and I get rid of the herniation, will the problems come back in the future? The answer is no. There's really two things. There's a big herniation. See that? Let's turn the light on. Show our guests. Can you see this? Right here?
Yes, we can.
All right. No, once I get rid of the herniation and I clean up the annular tear, it's called a debridement. The debridement of the annular tear is the key. As long as that's done properly, which of course I do it properly, since I'm the one who developed the technique, as long as that's done properly, then the herniation won't come back. The key is the annular debridement. You see, I'm the first person in the world that understood how important the annular debridement is. If you don't do the annular debridement properly, then what happens is the herniation will come back. And that's why a lot of people get reherniated discs. If they follow the instructions and they get a reherniated disc in their back or something, usually it's because the debridement of the annular tear wasn't done, okay? Has to be done properly. If the annulus is debrided, then the disc will heal. Just about done. For the disc to heal, the annulus has to reattach both sides of the tear. have to reattach. You understand? If they don't, then you have an opening there that will stay there, and the patient can get another herniated disc very easily. So the key to my surgery is to debride the annular tear, clean it up so that it's able to heal. If you don't debride the annular tear, it won't heal. If it doesn't heal, then another herniation can come back. When I originally published the surgery, I mentioned that in my publication. I made a very important point of it, that that's really what separates the Duke laser disc repair from all the other endoscopic spine surgery, is the annular debridement, which no one else does. All right. You have another question?
Yes, we do.
That's it.
One of our viewers is wondering, are there any non-surgical treatments for spinal compression?
Are there any non-surgical treatments for spinal cord compression or nerve compression?
Yes.
Well, you could try something called traction, which is where they pull your head away from your body straight out and see if you can unpinch a nerve that way. But it doesn't work, because as soon as they stop pulling on your head, your disc herniation goes right back to where it was. So unless you want to walk around with someone pulling on your head 24/7, the herniation is going to come back. So there really is no non-surgical treatment of a symptomatic herniated disc. Watch out for your scalpel. All right, let me show you this here so y'all get a good idea of what's been done. So this is her neck, this is her chin, okay? And this is the tube that the whole surgery was done through. This little tube right here. I'm going to show you the incision is very small. We always apply pressure because veins can bleed. So you want to apply some pressure. Get this out of the way, please. Get this out of the way. It doesn't belong there. So we apply a little bit of pressure for the veins for about 4 minutes. Veins are low pressure blood vessels. They only have 10 millimeters of mercury in them. That's the pressure of the blood in a vein. So if you push against it by 11 millimeters of mercury or even 10, the bleeding will stop. Arteries have whatever your arterial blood pressure is. What is her blood pressure? 100? So for me to stop an artery from bleeding, I have to push 100 millimeters of mercury. That's 10 times the amount of pressure that I apply for a vein. So to stop a vein from bleeding, it's 10 millimeters of mercury. To stop an artery, it's 100. All right, so can you see the neck here?
Yes, we can.
Because her symptoms, she's laying on her back looking up at you. Because her symptoms are on the left arm, we always go to the right side. So I always go on the side opposite of the patient's worst arm symptoms. So most of her symptoms are left arm, so I went to the right side of the neck. The middle of her neck is right here, right here. So I'm off to her right side, and I take a path between the trachea and esophagus, in the middle, the carotid artery, jugular vein, basically the carotid sheath and the sternocleidomastoid muscle to the outside. I go between them. And that's how I get to the spine. Here's the incision. Look how tiny it is. It's 4 millimeters. Put some pressure here. Her neck is supple. There's no hematoma. Great job, everyone. I'll take any more questions you have in the conference room. Go ahead and start typing them up. Great job, everyone. It went really well. Let's make sure we get her in a collar. And are we going to be testing any more x-ray machines? I'm afraid to know the price of that one. All right. Oh, my head.
All right, everyone, thank you for joining us for the post-op Q&A. We have Dr. Duke in the room with us now that we've wrapped up our surgery for the day. We're going to answer some of your questions. So we have a few questions coming in from Facebook right now. One of our first questions that came up was, Doctor, do you recommend fusion surgery to treat nerve compression caused by bone spurs, or is there a better alternative?
Okay. So thank you for asking questions. I'm Dr. Duke Majan, CEO and founder of Duke Spine Institute. The question is, do you recommend fusion surgery to treat compression in the neck, I assume, by bone spurs? The answer is simple. I've never seen a patient, not once in 23 years of doing neurosurgery, that only has bone spurs pressing on their nerves, okay? It's usually a herniated disc with some bone spurs. So what happens is they go see their doctor, they refer to a surgeon, the surgeon says you've got bone spurs. Just to keep it simple, to make an impression, to make you feel like, oh my God, I got something that needs surgery. The reality is that you may have a pinched or irritated nerve. It may not even be pinched that bad. It may be more chemically irritated by the herniation. So what you really need is you need the truth. To get the truth, you need to go to a doctor like Duke Spine, where we're going to look at your MRI and we'll tell you everything. We're not going to oversimplify things. If you oversimplify things, then what happens is you become limited in your options for treatment. So if this person who's asking the question really has only bone spurs pushing on their nerve, then you would be the first patient in the world to have only bone spurs. Everyone else has a herniated disc called the disc osteophyte complex by some radiologists, a disc herniation and a bone spur, disc osteophyte, disc and bone spur osteophyte. So bony intrusion or bony narrowing, there's so many different ways of saying it. But in the end, folks, the disease is the same in everybody. And I've never seen it be just bone spurs. So to answer your question, if you have just bone spurs, then I would recommend going in with a drill and drilling those bone spurs down, getting rid of them with a drill, and then fusing the bones together. But I can assure you, you don't have just bone spurs. As a matter of fact, you probably don't need that surgery, but I would need to actually see your MRI to be able to tell you whether or not you need a fusion. So the whole purpose of the surgery today, folks, is to open your eyes so you can see that fusion isn't the only answer. There's other new technologies that are now available, though limited to where you could go to get them, because that's how all new technology is. Whenever there's a new technology in the world, whether it be a stealth bomber, whether it be a nuclear weapon, whether it be a new surgery technique, it's always going to be available in a very specific place, one or two places in the beginning, because those are the people who pioneered it. And you know, those people who pioneered the technology, they're not everywhere. They're not omnipresent. They're human beings that live in a specific place and work in a specific place. So what I'm getting at is the technology of the endoscopic spine surgery you watch today, that is the future. There will be no more fusions done. There will be no more artificial discs done. If every spine surgeon in the world could do artificial disc, fusion, and Duke laser disc repair, what you watch today, they would all do Duke laser disc repair. The problem is they don't know how to do the surgery. So you're not going to be offered the surgery anywhere else. So if you want the most advanced spine surgery in the world that doesn't do fusion, that doesn't do artificial discs, that doesn't put metal in your body, that doesn't put plastic in your spine, that doesn't fuse bones together, that doesn't have any complications to date, then you're going to have to travel to Melbourne, Florida to have that surgery done. So the purpose of this presentation is to make you aware of the facts, the truth. And the truth is that there's better surgery than fusion out there, but the problem is it's not everywhere, and you're going to have to travel. We're seeing a consolidation in healthcare already. What's happening is the insurance companies in the United States are denying more and more tests and treatment. It's causing hospitals to close all around the country. And when hospitals close, what you get is something called consolidation. So now, if you live in a town that has a hospital that closed and you have a medical problem that needs surgery, you're going to have to go to the next town maybe the big city where there's a hospital there. We call that consolidation of healthcare services. Basically, it's a shrinking of the services that are available to you to fewer and fewer locations. So Duke Spine Institute providing the endoscopic spine surgery is no different. It's a consolidation of services, but not because it's shrinking down, but because it hasn't expanded yet. And so you're catching this surgical technique that's new. It's better than anything else available out there by far, yet it's not in your hometown. You're going to have to travel to get it done. So to answer the question of if I've got bone spurs, do I need a fusion? The answer is no. 99% of the time, the endoscopic surgery you watch today, which is done without fusion, is the solution for you, the best solution you could get anywhere. Now, is there a situation when the patient has only bone spurs and no herniation and they're huge? Sure, but it's extremely rare. Like I said, I treat thousands of patients with spine problems like herniated disc and bone spurs every year. I treat more spine patients than most 99% of spine surgeons. And I can tell you, I rarely, if ever, have seen a patient with just bone spurs. So I would have your MRI looked at for a second opinion. I'm happy to do it at Duke Spine Institute. We offer that service for free. There's no obligation to treat here. You don't have to come here and be seen. You can just send us your MRI and we'll tell you if fusion is the only option for you. But I would say, statistically speaking, there's a 99% chance you could have the endoscopic surgery without fusion to fix your problem, which would be much better than a fusion surgery. All right, let's take the next question.
So our next question that came in asks, if a patient has had a leg or arm amputated, how do you test for radicular symptoms from a herniated disc? And if they are present, do they still need to be treated as urgently as a patient who has limbs experiencing degradation of function?
That's a very interesting question. Thank you for asking. So if somebody has an amputated limb and they have a herniated disc in their back pinching a nerve, they certainly could have radicular symptoms. They could feel pain shooting down their leg even though they don't have a leg there. They could have numbness, tingling. Now, obviously, if you have a limb that's there and the limb is getting weaker or number, you need surgery right away. If you don't have a limb, then that risk of neurological deficit is not there because you don't have the limb to begin with. So it would be more of a comfort measure to do the surgery just to get rid of the symptoms. Now, if the radiculopathy is in a muscle group that's still functional on the limbless person, for example, if the nerve was the L2 nerve root that was being pinched and the person has amputation below the knee, well, you still need your L2 nerve root because you have an L2 innervation muscles that are still functional, causing hip flexion. So it has nothing to do with loss of your limb. In other words, the nerve is still necessary and functional because it's going to muscles that are still being used. In that case, you want to get it taken care of right away. So it just depends on which nerve is affected, and is it a nerve that goes to, phantom muscles and tissue, or is it a nerve that goes to still functional muscles and tissue that are still needed for the person to function for that lost limb? I hope that makes sense.
And our last question comes from a viewer on Periscope who asks, what is the size and brand of the scope that you use?
So the scope that I'm using in this surgery today is made by a company in Germany called Wolf, W-O-L-F, Wolf. And they've been making spinal endoscopes for many years, since the very beginning, probably for about 20 years, maybe longer. I was introduced to them about 16 years ago when I went overseas to learn how to do the surgeries. These surgeries were being done using the Wolf endoscopes. So I learned on the Wolf system, which at the time was the very best for endoscopic spine surgery, and I've stuck with that system for years. There are some newer systems, and they may become better, but I haven't really played with them very much. But that's something that certainly I could look into. But this scopes that I've been using are the ones that I've done all my surgeries on and had the great results with. So it's hard to change scopes to a different brand when you've had such good results with no complications for 15 years. Doesn't mean I won't try it, but I'd like to see some new technology at some point. I may actually be involved in the development of new scopes. So the scope is the Wolf Cervical Endoscope. As a matter of fact, Wolf stopped making this one, and basically I'm one of the only surgeons, if not the only surgeon in the world, that uses it.
That's our last question.
That was our last question. Thanks for being patient with us. Once again, my voice will get better over the next few weeks, as I just had sinus surgery on Friday, 4 days ago, 5 days ago now, and still recovering. But the surgery today went very well. This patient had 2 herniated discs in her neck. She traveled from out of state across the country, all the way from Kansas to Florida, because there's nobody else in the United States that does anterior cervical endoscopic surgery, the Duke laser disc repair, where we can repair a herniated disc, removing the herniation and debriding the annular tear to allow the disc to heal naturally, pain-free, without any effects on the nerve. And we've had 0 complications in 15 years and over 1,200 surgeries. Our patient should be able to go home in about 30 minutes. They're waking her up right now. She was intubated, asleep, with a tube down her throat on a ventilator, totally out of it for the surgery. That's how we do the cervical ones. For the lumbar cases, the patients are usually awake for part of the surgery, same as the thoracic. Duke Spine Institute is the world leader, literally the world leader in endoscopic spine surgery. We do cervical, thoracic, and lumbar disc herniations with endoscopic surgery, without fusion, without metal, without hospitalization. Everything is done outpatient. You go home an hour after your surgery. Most people go back to work within a day with restrictions on lifting and bending. Hope you've enjoyed the surgery. We'll be back again next week, right? And we're going to change the format a little bit next week. Sean and I are going to be we're going to try to get our patients to agree to do a preoperative interview, which will air before the surgery. You'll be able to see what kind of complaints the patient has before their surgery. And then we'll be doing an MRI review of their MRI with the herniations. And then we'll do the surgery live. And then hopefully we can do an interview of them afterwards. So it'll be sort of a combined educational format. Again, all of our surgeries are streamed live over the internet, free, with no charge to anyone. And we've been doing that for 6 years now. Thanks to support from the Duke Spine Foundation for Research and Education. Hope you've enjoyed the surgery. I'm Dr. Duke Majan. Till next time.